Good morning, everyone. See, people are logging in and trickling in through the virtual conference hallway here. I'm Dr. Sanjeev Socklingham, Vice President Education and Interim Physician-in-Chief at the Center for Addiction and Mental Health. And it's my pleasure to welcome you all with Dr. Leslie Buckley, who's our Chief of Addictions at the Center for Addiction and Mental Health. And welcome you all to today's Opioid Use in Primary Care virtual conference. It's exciting to see the number go up here as conference attendees continue to trickle in. And I'm sure that we will be having some rich discussions over the course of the day, and really exciting to see how many people are attending today. And I know that the attendees cover a broad range of experiences and expertise and diverse perspectives, which are really important to today's conference. Before we begin, I'd like to start with acknowledging the land upon which we are situated. And I'll say I'm dialing in from Toronto and at CAMH. So I'll be acknowledging the land where I'm situated. So CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes through the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at that time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805, with the Mississaugas of the Credit. And Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, share the land, and protect it for future generations. With that, before I hand it over to Dr. Leslie Buckley, I just wanted to begin by congratulating the conference planning committee and speakers today for creating a wonderful program, and also want to thank the Ministry of Health for the continued funding and support to subsidize this conference. Really, it allows us to have this opportunity to create this conference at a critical time as we continue to evolve and acknowledge the devastating impacts of opioid poisoning and the current crisis, and try to understand better ways in which to support people who use opioids through a variety of methods and approaches, including harm reduction, new treatment approaches, and models of care and support. So again, I look forward to hearing the dialogue, and so excited that we start with our lived experience panel. And with that, we'll hand it over to Dr. Leslie Buckley to share her thoughts and to introduce our co-chairs.
Thanks so much, Sanjeev. I'm looking very forward to hearing from this incredible group and of speakers today. And I also want to thank the organizing team for all their work and for putting together such a fantastic program. We all benefit so much from education and discussion like this, especially during this time of unprecedented crisis and rapid change. We're very blessed to have two incredible co-chairs for this conference, and it's my pleasure to introduce Sean Patenaude and NIkki Bozinoff. Let me tell you a little bit about Sean. So Sean is an artist, educator, and mental health advocate who has worked for CAMH for the past 8 years in roles focusing on restraint reduction, patient safety, and incident management, and is currently in the role of patient engagement facilitator. He's a graduate fellow of Let's Lead, Yale University's Transformational Leadership Academy, and a CPSI certified patient safety instructor. Sean has served as faculty on CAMH Education's Opioid Agonist Treatment Training Program and has been a guest lecturer at the Leslie Dan Faculty of Pharmacy and the Med Studies Program at the University of Toronto. As a public speaker, Sean has shared his lived experience and his message about the harms of stigma and the importance of patient experience with thousands of students, clinicians, and decision makers. Now on to NIkki. NIkki Bozinoff is a physician in the Concurrent Outpatient Medical and Psychosocial Addiction Support Service, also known as COMPASS, at CAMH. She's also an assistant professor and head of the Division of Mental Health and Addictions at the Department of Family and Community Medicine, University of Toronto. She is the current program director for the Enhanced Skills in Addiction Medicine Fellowship at U of T and a clinician scientist at the Center for Addiction and Mental Health. Her clinical work is in the management of substance use disorders and concurrent mental illness, and her research program seeks to answer clinical questions in the management of opioid use disorder. So with no further ado, I'll hand it over to our co-chairs.
Oops, did we lose Sean there? Nope. Okay, still there. So I want to welcome everyone today in my role as head of the Division of Mental Health and Addiction at the Department of Family and Community Medicine, University of Toronto, and co-chair for this conference. I would just like to thank the organizing committee as well as my co-chair. I think we've put together an exciting program for today. I hope you're engaged in learning and are challenged to move outside of your comfort zone. We know that primary care providers, because of their longitudinal relationships with clients, are well placed to identify and ally with clients who use substances. We know that also that clients often prefer to access treatment in primary care settings and that they get better preventative care when they do. I know that there's a lot of tensions in our work today between the crises in our healthcare system, the post-pandemic life, the ongoing deaths related to policy failure, and a toxic drug supply. So I want to just offer some dialectics, which are things that I've mostly been working on with my 4-year-old lately. Trying to do some distress tolerance with her, some dialectical thinking. So 2 things can be true. We're doing the best that we can in a broken system, and people who use substances deserve timely, high-quality care in their medical home. Primary care providers are working harder than ever to meet the needs of populations that they serve, and also there is room to improve. We are here because we believe that urgent action is needed to address the toxic drug supply. And also, we may have different ideas about how to do that. I hope that this thinking might be helpful to you as you use your own experience from today to inform discussions. We hope that today's event will be safe. In that spirit, we ask that you show respect for other people's opinions and differences. Your participation is needed for today's event to be successful, so please do share. And with that, I would like to sincerely thank you for taking the time to join us today, and I look forward to engaging with you during today's sessions. Thank you so much.
And thanks, Nikki. Hey everyone, I'm Sean Patenaude. I'm a patient engagement facilitator at CAMH and Nikki's co-chair, his grateful co-chair. So it's been an amazing experience being co-chair of this year's Opioid Use in Primary Care Conference. And more than anything, I want to get started so you can hear from all of the amazing presenters we have lined up. But before we get to our first session, our lived experience panel featuring harm reduction specialists from across Canada, I'd like to take a few minutes to recognize all of the remarkable people who've come together to make today happen. First, I would like to thank our speakers, who are some of the busiest people I've ever met, as well as some of the most interesting. We deeply appreciate each and every one of you giving up your valuable time to appear with us today, and I'm looking forward to learning from all of you. You know, it's always challenging when I can't get to everything I want to see at an event like this, but I'll surely be catching up on all the recordings when they're posted. And I'm going to encourage everyone to catch our keynote speaker, Dr. Christy Sutherland from the Portland Hotel Society. Dr. Sutherland will be speaking at 1:10 Eastern Time. Don't miss her. Many thanks to the CAMH education team, Asha, Carolyn, Khalid, Robin, Mega, and Rosalicia. You've all put in a mountain of work in a very short time to get this conference together while still being kind to brand new co-chairs, meeting close to impossible deadlines, and fielding so many emails. And then I'd like to thank the members of the Scientific Planning Committee. So Nitin Chopra, Tiana Costa, Laura Nixon, Ashley Smoke, and Nael Tamayo. And of course, my co-chair, Nikki Bozinoff, for putting your deep knowledge of the opioid environment in Canada, your sterling reputations as peers, care providers, and scientists, and your extensive contacts to Noble Use on behalf of the conference. We have, as you've heard, an exceptionally wide range of experiences, disciplines, and communities represented today, and I'm excited and encouraged by all the new connections that have and will continue to be made in this virtual space. I want to especially thank all of our lived experience presenters, standing up as people who use or have used drugs and as people who care for them. The work that you do as peer navigators, advocates, outreach workers, harm reduction specialists, work done often with little to no funding or organizational support, work done out of your homes, your cars, your drop-ins, and on your streets. Your work is saving lives every day. Thank you for being here. I can't wait to hear you. And finally, I want to thank all of you for attending. We know why we're here, and we know what the stakes are. Even among our tiny conference family, there are empty places set at this year's table. Let's listen to each other today. Let's learn from each other. Let's connect with each other, and let's carry on the work together. We enthusiastically invite you to give us your feedback on today's event by completing the post-event evaluation. This event is about meeting your learning needs, so let us know what worked for you, what didn't, and what you'd like to see in the future. And with that, I'd like to now introduce Ashley Smoke, who will moderate our opening panel, helping us ground all of ourselves in lived experience. Ashley Smoke is a First Nations drug user and community activist. Ashley does advocacy work and research. They consult on a variety of projects with Public Health Ontario, Addiction and Mental Health Ontario, Mount Sinai, CAMH, the Ontario Opioid Policy Research Network, the Dr. Peters Centre, among many others. They helped create and currently serve as Vice President of the Ontario Network of People Who Use Drugs and the Peel Drug Users Network. Ashley was most recently hired at the Ontario Aboriginal HIV/AIDS Strategy as the Indigenous Harm Reduction Knowledge Mobilizer. Congratulations, Ashley, and take it away.
Thanks, Sean. Before we begin, I just wanted to begin by remembering someone that was on the panel last year. Alexandra DeCoit passed away this year, and she was on our panel last year. And Alex and I had met doing a project with Health Canada around drug checking technology. And we were on the jury panel, and we kind of forged an alliance, I guess, as the two people with lived experience. And then from then on, we kind of made we kind of did a lot of different projects together, and we had a good friendship and a good working relationship. And I really miss Alex's spunk and personality and just willingness to say whatever needed to be said in the moment. And Alex was a really big advocate and a really strong person, and I just wanted to remember Alex and just have a moment of silence for Alex and all of the other people who use drugs that we've lost this year, that we work with, that we live with, that we care about. So now I'd like each of the panelists to briefly introduce themselves and why they chose to be here today. I guess we can start with Katie.
Hi everyone, my name is Katie Upham. I use she, her pronouns, and I live in Mi'kma'ki, colonially known as Nova Scotia. I'm the harm reduction educator of the Substance User Network of the Atlantic Region, or SUNAR, which is a drug user union with members in all 4 Atlantic provinces. I'm a person who injects drugs on a daily basis, and I'm on prescribed safer opioid supply. I'm here today to share a bit of my living experience in hopes that it might create positive change in how healthcare providers treat and care for people who use drugs. Thanks, Ashley.
Thanks, Katie. Marcie?
Hi, I am Marcie McIlveen. I am a person with past lived experience of substance use and so many other things that go along with it: criminalization, hospitalization, forced and non-voluntary treatment, which is a hot topic in today's society. I've done that 15 times and was not successful once, but that's a whole other panel and conversation. I am here today in my role as a person with past lived experience and current experience as program manager for Hamilton's Only Safe Supply program.
Thank you. Sylv?
Hey folks, my name is Sylv Newhook and I use they, them pronouns. I am a peer outreach worker with the Substance User Network of the Atlantic regions from Upham, colonially known as Newfoundland, and I am based in St. John's. I'm also the co-director of a virtual youth program called Heart to Heart NL, and I have living experience of drug use and lived experience of opioid agonist therapy, sex work and homelessness as a teenager or young adult, and I firmly believe in the importance of connection within our communities to working towards putting an end to the epidemic that we are currently facing. So that's the reason I'm here.
Thank you. And Lauren?
Hi, I just want to do a quick land acknowledgement. I'm a settler on Treaty 7 land, McKinstis, colonially named Calgary. I just want to honor and acknowledge the territory and oral practices of the Indigenous peoples of Treaty 7, which includes the Blackfoot Confederacy, Siksika, Kainai, Piikani, as well as the Stoney Nakoda and Tsuut'ina and Métis nations, all disproportionately affected by colonial violence, including the war on drugs. So my name is Lauren, pronouns are she, her. I'm a peer navigation coordinator and peer researcher for the peer-led Calgary chapter of AWARE, which is the Alberta Alliance who educates and advocates responsibly. I'm a frontline outreach worker serving with other people who use drugs. I do my best to fight against the stigma and harms caused by oppressive drug policies. I have lived experience with OAT, survival sex work, houselessness, and highly criminalized drugs. I'm super grateful to be here with all of you, and I'm happy your voices are being included in this conference. I'm here to share my lived experience and hopefully some positive changes will come out of it.
Yes, that's the goal. So I guess we can just start with the questions. The first question we have for the panel today is, what do we mean by safer supply, and how can it improve the quality of life? Katie, did you want to start?
Sure, yeah, thanks, Ashley. So safer supply, and I'm going to assume we're talking about a medical model, is when prescribers provide people who use drugs with a pharmaceutical alternative to whatever drug they are currently accessing on the street. When done correctly, it is provided in a flexible, low barrier way with access to wraparound health and social supports if people want to access them. Safer supply is harm reduction in practice. Many people are unable or unwilling to stop using drugs, which safer supply programs recognize and accept. Safer supply is a great option for people who have not found benefit from traditional forms of OAT, or the side effects of OAT are not tolerable. Safer supply can also be used in combination with OAT. A current challenge with the medical model of safer supply is that many programs are not able to offer the same pharmaceutical grade option to the unregulated drug that people are using, such as cocaine. We don't have a pharmaceutical prescription that we can offer, or people can't use it in the ways they prefer, like smokable options. And yeah, I mentioned earlier that I am currently on safer opioid supply. So I'm prescribed allotted tablets that I pick up every second day. I'm allowed to take those home and inject them. I think my story is important to share because I feel as if most people would think that if you gave someone like me drugs to take home and inject, that they would happily do that forever. I don't think there's anything wrong with doing that forever, but that's not always the case. So without pressure from my doctor, I've been weaning down off of my safer supply. I started on the program in the beginning of March of this year because I relapsed after 2 years of being abstinent from all opioids. And I really believe that safer supply has saved my life. If I didn't die from an accidental drug poisoning, I would have likely lost my job because it's incredibly time consuming trying to find drugs on the street to stay ahead of opioid withdrawal. When I started using again and found I was unable to stop on my own, I was unwilling to go back to traditional forms of OAT because of the carceral practices and stigmatizing or judgmental attitudes I experienced from staff. I often felt punished and controlled if I did use street opioids while on OAT, so I just refused to go back to that program. I honestly would have rather keep using street drugs and risk dying from toxic drug poisonings. Like, that's how negative my experiences were with OAT clinics here. My experience with safer supply is much different. My doctor and I are a team. They respect my goals and my limitations. I dictate how fast or slow I come down off of my medication. I suggest when I would like to drop and by how much. And they do as I ask. My Safer Supply doctor is extremely patient-centered, flexible, low barrier. They know I work full-time and I live an hour away from their office. So we talk on the phone once or twice a week, tell them how my recent dose drop is going and, whether I want to hold at the dose I'm at or go back up. My prescriber does not use drug urine screenings in a punitive way. They only administered one when I first got on the program, just to confirm opioids were in my system before they started prescribing to me. I feel supported and respected in a way I never have with any other doctor. I actually feel that they trust me. Their ability to meet me where I'm at makes me want to stick to my goal of being abstinent again, because that's, for me, what I want, and to continue weaning down even though it's hard. I've started taking some pills by mouth, although I've not been pressured by my doctor in any way to do so. They know that I inject them. They don't give me a hard time about it. I started at about 7 tablets of 8 milligram Dilaudid in early March, and I'm down now to 10 milligrams daily. So I'm super proud of my progress. Thanks for asking, Ashley.
Marcie, did you want to share about your experience?
Yes, for sure. So like everything Katie said, thank you so much, Katie, for sharing your story, because stories need to be told, especially in the climate in today's world and what's happening in media and that sometimes healthcare, no offense to doctors in the room, but everybody's taking these polar sides. But I'm not going to go on a rant. I'm going to be very quick. I see Ashley nodding. She's like smiling. I think she's heard me speak before. As I said, I am program director for SAS. I'm wearing the shirt. I don't know. I didn't mean to, which stands for Support and Safer Supply. We are a program that focuses on community building and offers many opportunities to patients if they want them. No one is pressured in any way, but we started with one physician, there were 2 physicians and I think 10 or 20 people, and we now have about, I think, over 80 patients actively on Safer Supply, mainly opiates. We also have some people doing on stimulant, Safer Supply. Again, not equivalent to cocaine, but most people with methamphetamine and other substances. We talk about quality of life of Safer Supply. So the reason, one, it's called Safer Supply, not Safe Supply. Safe Supply would be a regulated, available form of any drugs people want to use, and we're not in a world that provides that currently. I know BC, and I think we're going to hear about it later in the day, is starting a fentanyl powder program. I don't know tons about it. I want to learn more. But in Ontario, that's not available. I'm in Hamilton, Ontario. The Ontario government is very, very direct on what they allow people to prescribe and how they let people prescribe it. But one thing we do offer is peer training for patients if they want it. We offer paid employment for patients that are current patients. We do not ask anybody to stop using. If people want to go the route of tapering off or abstinence, we obviously support that, but we don't set goals for people. We allow people to set their own goals, which sets us apart from a lot of treatment modalities where people are told, okay, this is what success looks like, and this is what recovery looks like, and this is how we know you're doing well. For us, it's you show up, you tell us what you want to work on, and we work on that. And even if there's nothing you want to work on and you just are I don't want to use as much fentanyl, or I just need to not be sick, then we do that. And if you want to change your entire life, we do that. Whatever people want to do in the moment. And that's what quality of life is allowing people to make their decision, meet people where they're at without trying to get them to go anywhere else. And Safer Supply allows that to happen. I personally was on OAT, and I don't want this to be a anti-OAT thing. I know people that it has worked extremely well for. I know people residential treatment has worked well for. When I was on OAT in 1999, I was kicked off of the program due to urine drug screens. We do them in our program. We do them to just see what's in substances. The toxic illicit drug supply has a bunch of stuff in it, and people coming off fentanyl and switching to Safer Supply. Pharmaceutical opiates means that they're not going to have as many benzos, and benzo withdrawal for the doctors in the room and people in the room is extremely dangerous. So we need to know what people are taking, what's in it, and people want to know as well. So we don't do it in a punitive way. We don't cut people off or change their medication based on what's in their urine. We talk about what is and what isn't showing up and what that means for that person. But yeah, safer supply creates a quality of life, as does other programs for other people. But I think we need to live in a world where everybody has an option. My husband has cancer, and if he was only given one treatment option for his disease, I don't know if he'd be alive today. And we treat substance use disorder as an illness, and we give it one option in a lot of ways, maybe two, where like you can do OAT or you can go to rehab, and that's what you can do. And when that doesn't work, people die. Safer supply creates a bridge and allows people time to look at what they want to look at, and maybe like follow Katie's path towards like abstinence from opiates, or maybe not, maybe just make some changes. And yeah, that's it for me. I went on a long rant. I'm very sorry.
Thank you so much. Sylv, did you want to share your perspective?
Yeah, thanks, Ashley. For me, safer supply, using drugs shouldn't be a death sentence. And people's choice to put their substances in their bodies should be their own personal choice. People use for all different reasons. Some people just use once in the blue moon. Some people have substance use disorder. So it's just, for me, safer supply would have meant a whole world of difference for me. I was on the opiate agonist therapy program, and I had to get taken off because of issues that started giving me with my bowel due to a car accident I was in. And then I was basically just cut off from whatever level, just automatically a doctor to take me off. And the thing is, I always struggled in the beginning of OAT I was still using as well on the side, because I felt like I was not getting the stuff needed for quite a long time with OAT until I was on a much higher dose. But which was in turn also dangerous because I was using substances and the methadone at once. So I think I would have been done better with safer supply, but it's not offered in Newfoundland, to my knowledge. It wasn't offered to me. It hasn't been to friends, but it would definitely change people's lives if it was offered, for sure.
Thanks. Lauren, did you want to go next?
Sure, yeah. So prescribed safer supply is one intervention for an alternative to the toxic, illicit, unregulated drug market. These pharmaceutical grade drugs like hydromorphone may be safer, but they're generally not strong enough, and they're inaccessible. A lot of times there's wait lists. Most people who use drugs don't qualify, and it's restricting in where you could access. Especially in Alberta, in Calgary, they recently created a policy that you can only go to one pharmacy to receive it. So how can anybody live any quality of life by being limited to one location? They can't get carries, and they have to find transportation a few times a day. I feel like that makes it impossible and unsafe. There's also this misconception that OAT is safer supply. I've heard that drugs like methadone and hydromorphone are safer, but they're not enough. I think drug user-led unsanctioned compassion club models like DOLF, the Drug User Liberation Front, implemented would be ideal, where drugs are bought and tested and resold that properly fight dope sickness. So I feel like we need the closest medical version of the street drugs we use, like, for example, diacetylmorphine for heroin, or just straight pharmaceutical, unadulterated fentanyl, meth, coke, all of it, instead of like this illicit crapshoot that we get today that's tainted with benzos or xylazine and causing all these complex poisonings that Narcan won't work on. I also feel like we need to have that same feeling and reaction to the drug. Otherwise, it's going to be pretty tough for a lot of us to improve our quality of life. What sense does it make to give somebody who's addicted to a drug like fentanyl a way less potent drug? They're just going to go back to the black market to substitute. I feel like if we really want to stabilize, it's important to keep our drug dependency satisfied. This way we can work on other social factors of our lives, like housing or employment, family, maybe even like our own form of recovery. For me, methadone was a major factor in lessening my chaotic use of opiates. These days I have a much healthier relationship with opiates. But I also had to supplement with street drugs while I was on it. As I wasn't getting anywhere near that cognitive relief that I craved, I needed that, or else I was going to be in survival mode. And I couldn't stabilize just with OAT. I needed relief in my own way. So I feel like doctors should be giving patient-centered care and respecting people's level of pain management.
Yes, and it doesn't always just have to be in like a program necessarily. It can look like a doctor just providing their patient with the needs that they have. Anyway, so the next question is, what is meaningful engagement of people who use drugs, and what are the benefits? So I think this panel knows a lot about this. Let's start with Katie.
Thanks, Ashley. I'd kind of like to use example of research. I think that some of the same principles can be applied to different situations. So in research, meaningful engagement to me means it's done in equal partnership with people who use drugs, including through the use of peer researchers. Researchers should be decentered, and the needs of the community should take priority. Involving people who use drugs in every step. So that means talking to us about the study design, what we would like to be studied, I think is really key. And like what research would benefit our community so we can advocate for certain changes. And sharing the results with us, their implications, that kind of stuff afterwards. There should be some reciprocity between researchers and the community. And that historically, I don't think has happened a whole lot. I would say that community-based research guidelines and ethics are very important to create like meaningful, respectful engagement. When community-based experience is combined in a collaborative way with academia, becomes a much more respectful and meaningful situation. Furthermore, I feel that critical participatory action research is the approach that should be taken. So it leverages scientific research in a way that's actionable to combat social injustices that the research itself explores. That's how I'd like to see research done. When being a participant in an interview or focus group, I appreciate it when the interviewer or facilitator has lived or living experience themselves. So that can be a benefit of engaging with us and having us in those positions, because I'm more likely to share openly and feel heard and respected with what I do share if, the researcher has lived or living experience too. Giving people options and being flexible is key. Options in how they participate and in how honoraria is distributed and when. Also making best efforts to accommodate barriers to participation, especially for the most equity deserving populations that could face challenges in participating. Being paid appropriately for my time and expertise is really important without having to fight for it or even ask for it is a much better experience. If you're asking someone who uses drugs to dedicate their time to a project or speaking engagement, policy development, research, anything really, we should be paid equal to that of other experts. You should also tell us upfront exactly how much we'll be paid and how. For example, if you pay us for an hour-long meeting, but you also expect us to review slides or documents to prepare for the meeting, we should be paid for this time as well. This conference is doing that really well. They said up front that they would be paying us for our prep time and trust us to, account that accordingly, and fairly. And I really appreciate that. Before agreeing to be part of research or any other engagement that utilizes my expertise with injection drug use, I look out for red flags like paternalism and tokenism. The intentions and motivations behind the project are important to me too. If it will not benefit the community of people who use drugs, I'm likely to say no. On the other hand, if I see a specific plan to collaborate with people who use drugs from start to finish and it's outlined, and I see willingness of the organization or person I'm working with to put people who use drugs in leadership positions, that's a really good sign for me. I look for indicators of power sharing, credit being given to our contributions, co-authorship, that kind of thing. And ultimately, I think the benefits of meaningfully engaging with people who use drugs is that it creates a better final product. It creates policies, guidelines, and procedures that support the rights of people who use drugs. Very well-meaning people who just, they don't have that lived experience, have created, not meaning to, but created really stigmatizing practices and policies. So that's why it's really important. And I think for me, it's helped to heal some of the historic harms that's been done to people who use drugs by society. When people really engage me in a good, respectful way, it feels really good. So yeah, that's what I would say. Thanks.
Okay, let's switch it up a bit. How about Lauren? Do you want to go next?
Sure, yeah. I got a few things to say on this. Meaningful engagement, broad topic. I worked in research as well as a peer researcher for a project called Karma, which was Cannabis as Relief in Mental Health and Addictions. And meaningful engagement meant that it was important to fully include us in the process. I was invited to be part of almost all the steps. Like you said, Katie, that we're often tokenized in these projects. Meaningful engagement means including us in the whole process. We are experts and the main stakeholders, so we're the ones best suited to discuss our reality with you and our peers around issues that affect us. Being a part of committee meetings, discussions, planning meetings, survey development, journey mapping, and given education and research, I feel like we're key to the success of this project. Like we say, nothing about us without us. So meaningful engagement should benefit the communities and people that they're meant to serve. I feel like if you're involved in a project or a study that isn't inclusive of the population it's about, ask yourself why, and is this going to cause harm? And read up on the best practices for meaningful working with people who use drugs, or whatever population you're studying. CAPUD's Canadian Association for People Who Use Drugs, see us, hear us, respect us. It has best practices that you should read before. In a primary care setting, I believe another way for a meaningful engagement is language. It can support and change the narrative around drug use. Language is a small change that can make a massive difference. Using words like addict takes away from our humanity. We're people first, and just because we use drugs doesn't always mean we have a substance use disorder or an addiction. Having meaningful engagement with us means letting us decide the life we want to lead to and not have a paternalistic way of responding to our drug use. Everyone uses drugs, so I feel like just normalize it. The main focus should be keeping us alive. I'm also still hearing it called an opioid crisis. It's a drug poisoning crisis. Opioids are neutral. The problem here is the toxic drug supply. The crisis is prohibition and drugs being unregulated, the same way alcohol was poisoning people 100 years ago. The IR law of prohibition means drugs will continue to become more and more potent until these deadly drug policies change. In Alberta right now, they may implement forced treatment, which is terrifying. It's a human rights violation, and it will be a death sentence to the drug using community. We can't be coerced into abstinence. We'll only use when released and will die from lack of tolerance. I feel like it's important to keep this in mind in primary care. If your patient isn't ready for change, any sort of convincing will only cause harm. Meaningful engagement means respecting us where we're at, and lessening those power differentials by hearing us. Don't assume that we want to quit and gatekeep drugs. Build trust by humanizing us and normalizing drug use. We know ourselves and should be in control of making those decisions when it comes to our health.
Thank you so much. Sylv, do you want to go next?
I could. Well, you folks have really touched on an awful lot of it. But I think that for me, with the research side and everything, I think for me, with meaningful engagement of people who use drugs, when we're speaking about our communities and stuff like that, I am a peer outreach worker for Sooner, and I'm noticing more and more people that have been asking me, like, how do I get involved? How can I be part of stuff like this and things like that? And I think we need to have more interaction with folks, including people like in different things. Like maybe for me, I know it's given me a chance to get out and make connections with people in the community who have been told for years, like, to cut people off from their old past lives and stuff like that. And it's just great to see. Sorry, go on to someone else there for a second. My thing.
Okay, that's fine. Marcie, did you want to go now?
Sure, yeah. What is meaningful engagement? There's so many ways that this can be addressed, but let's, I guess, focus on like healthcare settings. We've talked a lot about like research and primary care. I think a big thing is sharing your own humanity. Meaningful engagement with people who use drugs is the realization that everybody uses something, and we shouldn't be looked at, like, not looking at someone different because their substance is different than yours or their substance is illegal or whatever, right? Like allowing people to be part of the whole process, allowing a community, not being us and them, or I'm a doctor, you're a patient. Something that happens, I see a lot now, that people, like physicians, using their first name instead of this is doctor, like whatever, this, I'm this person, I'm that person, like bring your name. There's something in the chat about like sharing their own experience. And I think I started teaching recently as a sessional instructor at McMaster, this course called What Trauma Teaches, and it's talking about, when we try to teach about like bringing yourself to where you are, whether that's work, family, relationships, or community, to show up as you are authentically, and realize that the person in front of you is story is just as valid, or experience is just as valid as yours, and education isn't always found in textbooks. And what does it bring, and what are the benefits of engaging with people who use drugs? Is it gives purpose to pain. It gives a path, right? It gives awareness that substance use and substance use disorder are two totally different things. I'm a person with substance use disorder. I understand what you're saying, Lauren. I can call myself an addict, doesn't mean other people can. I have the right to call myself what I want. It doesn't give you a right to define me as that. But a substance is just a substance. It's looking at the quality of life. It's looking at the person beyond whatever poison they put in their body, right? Because sugar and alcohol and weed are just as bad as cocaine, fentanyl, and the 400 Gravol tabs I sniffed off the floor in a group home when I was 12. I did. It was great. We just, like, it was bad. It was bad. CIS didn't love it. But it's just allowing community, allowing connection. There's this line, the line, like, nothing about us without us. And there's also, they talk, we die, right? But if you allow us to talk, maybe we can give some hope and people might live.
Yes, thank you so much. It's really about respect and just treating people like equals. Like, as a consultant, we get paid as people who use drugs about a third of what consultants make in the field, and it's not okay. So next, how is the people who use drug community standing up for each other as the toxic supply crisis goes on? Katie, do you want to go first? No? Okay. Marcie.
So the question is, like, how has community stood up for each other in the drug toxicity crisis? I think, and I'm going to go back, and I know, like, the present crisis is a lot different than the crisis before, but, like, substance use has always been criminalized. Was not always criminalized. Opiates were available and made in factories at one point. And then, like, racism came in and decided drugs are illegal, but that's a whole other thing. And I think we have to look at the fact that people show up for people all the fucking time. Sorry, I'm gonna swear. I'm sorry, CAMH. I love you all. We work in SAS and Keeping Six, and Ham Smart Works partnered with the YWCA in Hamilton to open the second only women and gender diverse CTS and urban urgent public health needs site, not a CTS yet, but the only women and gender diverse only site in Canada, second only. Other ones in BC, and we're doing this medical directive training, and we're having, like, doctors and, like, healthcare providers, And one thing one of the physicians said, and they'll stick with me, is the people that know how to respond to overdose are the people that have overdosed, right? Like, we know how to take care of each other. We will speak up for each other, even when things are wrong, right? I think, like, Sylv, you talked about some stuff, and I'm sure you'll share about, like, what's going on with non-sanctioned OPSs kind of thing, right? Like, my life was saved through people reviving me. I'm not going to say how. When I overdosed on substances prior to 2013, when there was no CTS and naloxone wasn't something you had, there's a whole bunch of other ways. If people ever want to hear about it, I'll put my email address, but none of them were probably great or medically approved. I think we just show up for each other by, like, loving and supporting each other. You'll hear in the news how, like, diversion is this horrible thing, but diversion saves people. People divert medication and other people live. Instead of going back to fentanyl, they're able to, like, get something that keeps them alive. We support each other by standing up, by looking out. There is, I'm not going to lie, there's dangers of drug use. The 7th or 8th principle of harm reduction is we don't deny the effects and negative effects and harms caused by drugs. Part of that is drug policy. Part of that is when I use drugs, I sometimes turned into an asshole. Not gonna lie, right? Like, I've done that. I've done some stuff that wasn't great to the people I love, but when that person was in crisis, I saved them, and I was able to respond and support them. I might have robbed you yesterday, but I'm hugging you today, and I'm okay with that because those people are still in my life and still alive today. So we show up even in the times we don't want to, because we know at times no one else will.
Yeah, and earlier we were talking about safe supply, meeting people's needs, and not actually doing that. And then we demonize people when they divert. It's kind of, I don't know, it's like hypocrisy. Katie?
Oh, I was just gonna say I feel more prepared to speak to this question now. I think creating drug user unions, like, we're seeing more, like, we like organize ourselves, like, as this toxic drug crisis goes on. I see more and more drug user unions popping up, like Sooner and OnPut. We've got the Canadian Association of People Use Drugs. We've got Aware. Like, we organize, and a drug user union, for people that don't know, does a variety of different things. Outreach. We advocate for better policies and practices and harm reduction, and policies that are going to support us and enable us to live, and not just live, but have a good quality of life. So I think that's one way we stand up for each other. Programs like NORS as well, like the National Overdose Response Service, created by people who use drugs, for people who use drugs. I'm a volunteer on that line. I think that's another great example. People can call when they're about to use drugs. Just gonna put in a plug for NORS really quickly. And it's like an overdose or safe consumption site over the phone, right? So if somebody uses on the phone with me and then they become not responsive, I've got their address, or I've got a safety plan. So they might want me to call an ambulance, but they might want me to call a friend next door. And so we give them those options, that flexibility again, right? A lot of people have experienced trauma at the hands of the healthcare professions, or police sometimes show up at overdoses, right? Like, we care for each other by, we know now if somebody has experienced an accidental drug poisoning and naloxone's not working, or we need support, we'll call and say somebody's unresponsive, because then police are less likely to show up. Like, we learn these tips and tricks rather saying, like, somebody's overdosed, right? That's gonna bring police usually, unfortunately. So we do those kind of things to stand up for each other. I think going to the hospital with another person, like, a lot of people are unwilling to go to the hospital to get abscesses treated or infections, and it's shocking, especially in Nova Scotia and Cape Breton in particular. People are dying of sepsis and, like, very treatable infections, because it's like they would rather die than face that kind of stigma and judgment. So we go with one another to the hospital, and I find when you bear witness and you're there, like, with somebody, they're less likely to treat you like crap. Yeah. And so I think there's so many ways that we stand up for one another. I think, Marcie made a really good point about diversion as well. Like that's one way we take care of one another, right? I'd rather give somebody, a safe supply than have them use the toxic drug supply and potentially die. I'm not going to say that I have diverted my meds because I'm not going to say that, but like that's things traditionally people have done. But yeah. Okay. Thanks.
Sylv, I saw a hand up there.
Yeah, the whole talk about stigma and like people dying because of it, I've had multiple friends recently that they would have clean time. I hate using the word clean, but and they'd be afraid to say to one another, like, hey, they'd be afraid to reach out to one of us and say, hey, I'm feeling like this or feeling like using. And we've lost them because of the toxic drug supply, and they were out of it for so long, and they didn't really know, hey, I should check my stuff, or hey, I should have a spot or anything like that. So so many of our friends here in Newfoundland have died due to that reason, that we've started kind of having our own informal spotting houses set up. So because we do not have an OPS in my community, and it's just been amazing to see people come together. If you give people the chance and you give them the opportunities for education and everything, like to help support one another, you will see people take on those big responsibilities. Some of my friends have even paid to get their own first aid training, so that they can have access to someone else if they need it for naloxone and stuff. We've already helped with, I'd say it'd be about 9 or 10 accidental drug poisonings that needed naloxone and medical help, medical attention in the past like 4 or 5 months. And I'm happy to say everyone who we were spotting did survive, and it's because we were there, we knew what to do. Yeah, we just need more people out there trained. I think we need an OPS for sure in the province, but that's something that people have been doing in my community to kind of help with this toxic drug supply and trying to change things. And it's just amazing to see people coming together to save one another's lives. So,
Lauren, do you want to go next?
Sure. Yeah, well, we're out there, we're in the community administering naloxone on the daily. We're standing up for each other by patrolling the streets and outreach, and we're stationed in parks to give Narcan. Like just in the last 24 hours, 3 people on our team have administered naloxone to folks, our street friends. We're training the general public on the importance of harm reduction. We're giving drug alerts when a batch is dropping folks. We're fighting for our lives, literally, and against moral, conservative, abstinent-based only approaches that are not evidence-based. We're advocating for change by hosting unsanctioned OPSs. We just had one last week with doctors and nurses who are fierce allies and advocates for harm reduction. Yeah, we're doing some civil disobedience, so it's justifiable because like that should be number one, is keeping people alive, keeping your patients alive. We're fighting for decriminalization, safe supply, and the importance of having more SCSs, especially for inhalation. We don't have that here. We have a community engaged learning program where we take out med students to gain perspective from people who've lived in living experience with drugs, and we bridge that divide. We guide them on issues that we're experts in that affect us, and share the importance of being trauma informed. Truly, they can see firsthand the way unhoused people are treated and the struggles and systems that fail them. We truly are the first responders, and stress the importance of all of us working together to fight for changes of these oppressive drug policies. Another way we stand up for each other is we have a program at Aware. It's called Be Best Foot Forward. It's a low barrier service in a community resource center. So community members are treated with dignity and respect, and there's a harm reduction focused doctor there and community paramedics on site who we partner with to care for our guests. It's a welcoming place where folks trust the doctor, as opposed to like the often institutionalized hospital setting where there's police criminalizing people for rightfully being frustrated. And in that environment, how are you supposed to heal in a place that may have caused you harm or trauma? I know peers that avoid going to the hospital altogether because of how comfortable it is. I recently had a like full-blown panic attack in emergency, and not one doctor or nurse even asked if I was okay. This would never happen in this community-based setting, like that Best Foot Forward clinic.
Yeah, I think one of the ways that I've seen communities stand up for each other was like Sylv was talking about. We started an unsanctioned OPS locally, and we've actually coordinated with other unsanctioned OPSs, and we've created a network of OPSs. So I feel like just like our ability to organize through the stigma, through the oppression, through the hate, and the communities right now with the political climate the way it is, treating us like garbage, I feel like we still survive and we still stand up for each other, and we're still more caring of a community than I've ever seen. And it's not even just us, like there are parents who have lost children who are working in the OPSs. There are teachers that are working in the OPSs. There are nurses, doctors, like social workers, you name it. So I think, yeah, we need to open our minds a little bit. So speaking about the political climate, maybe I'll just ask, how has that been affecting the work you've been doing and the organizing you've been able to do? Marcie, do you want to start with this?
Sure. I'm gonna try to like keep it brief and keep it like kind of neutral. I'm sure everybody is aware of articles that are out there and sides people are taking and all of the stuff. There was a motion that I think is getting voted on in Parliament next week about, I don't know the exact words of the motion, so forgive me if I misquote it, but it's pretty much around the ideas of taking funding away from safer supply programs. And I think as well as maybe CTSs. I'm not sure about CTSs. I know that's provincial, but I think like federal health dollars to go to treatment and recovery as opposed to harm reduction and all this stuff. I think in like a general way, it's affected us by causing stress, right? But I think like one thing that we try to do and try to remind ourselves and the people we work with is we're just going to keep doing what we're doing in spite of what might come. Again, there's always been stuff. The political climate is changing. There's videos, there's attack ads, there's people who will remain nameless, mainly because like in articles they won't give their names. In the National Post article, there was like doctors that were not going by their names, saying all sorts of things. And again, I'm not here to attack. I'm not a big fan on fighting. I used to be, and it got me nowhere other than like handcuffs in hospitals. So I think what I try to do is just show up and continue doing the work and walking with people on this journey wherever it takes us, and seeing the fear and seeing the panic is sometimes, right? Because this is people's lives that people are trying to like change because they don't know the people. And I think a big thing is to bring humanity by having panels like this, by sharing stories, by all this stuff. And I think one thing that we're not going to do in politics is, because like no amounts of stats or facts or evidence or research is necessarily going to change the minds of the people that believe what they believe. I think we just have to keep showing up and doing what we do, and trust that what we do is in the best interest of the people we do it for, and that they support us, and that we keep finding ways to do it.
Thank you. So eloquent. Does anyone want to say anything to this? No? Okay. So another question that was here, somebody was asking about what an OPS is. So I know like we can explain like exactly what an OPS is, but also can we also talk about the community that comes out of having an OPS as well?
if I can jump in like really, really quick, I think too, we just need to, acronyms are like everywhere, right? I have this conversation with my husband all the time because he's like older than me and acronyms are great. So OPSs are overdose prevention sites, now formally known in Ontario as consumption and treatment services for people in Ontario, because they said overdose prevention sites, increased drug, like the names and language, right? They're like, if we call it overdose prevention sites, we're like enabling use, so we're just going to change the name. And then the thing we have at the Y is an urgent public health needs site, which is at our open exemption and doesn't have provincial approval or whatever. So I think it's just talking with the community. It's a place where people come and can safely use substances. Some places have drug checking at them. There's unsanctioned OPSs, which is like peer witnessed or peer supported use. There's overdose prevention site like NORS, which is like virtual overdose monitoring. And I think it's more about, obviously the crux of it is to save lives, but I think it's about building community and having a safe place to show up. And the evidence and facts, if you want to go that way in stats, like increases people's access to like resources that they wouldn't have using in a park or alleyway.
Yeah, and like if you look at Moss Park, for example, that was an unsanctioned site that popped up in the middle of the park. And the community that was created out of just like drug users standing up for one another and keeping each other safe was amazing, and it brought so many people together, and it was such a good experience. So yeah, I hate that we call unsanctioned sites like illegal and people just disapprove of them because they have attitudes around drug use and they don't understand. Katie?
Yeah, I just wanted to speak to my experience with this briefly too. Like in February, we had a conference, or not we, Sooner and stimulus program put on an Atlantic-wide conference in February, and we knew that people who used, like 80% of the people there were people who used drugs. That was who we wanted there. And we knew they were going to use drugs. So we set up one of the hotel rooms was an unsanctioned OPS. Like, we know people are going to use drugs. We don't want them to die, because that's one thing you have to consider too. If you bring people who use drugs from out of province and take them, and we were all in Moncton, New Brunswick, and in the Atlantic provinces, Moncton has the most toxic supply. You know, it's really, you're killing people, I feel, if you don't have an OPS and there is one in Moncton, but very limited hours. And so to me, like, that is that you have an ethical, moral responsibility. If you're going to bring people who use drugs to a conference, and you should, you need to make sure that they can use safely. So I scheduled people around the clock to work in that OPS. They were paid appropriately. We made sure they had training and experience, and no one died, but there were toxic drug poisonings, and so I'm really glad we were able to do that. So I just wanted to add to that. And I think there was also a question in the chat about diversion as well. I was gonna just pop in the chat real quick. The National Safer Supply Community of Practice created a doc called Reframing Diversion that's written really well, and it was written with other safer supply doctors, people who use drugs, pharmacists, like a lot of very qualified people. So I'm just gonna pop that in the chat as well if we don't have time to address it fully. Thanks.
Sylv, did you want to speak to this?
Yeah, actually, I'll be honest, I was one of the workers in the non-sanctioned New Brunswick OPS section, and there was toxic drug supply found in there. But the fact is that because we were together, we were prepared, and, you know, we were having open conversation with one another. We were able to keep everybody safe and everybody alive in that situation. And I think that's just the main point of this is, you know, like, stop the stigma of people who use drugs being bad people and stuff like that. Like, you know, we're all caring for one another. We all love each other. We're all human. We all have families and friends, and, you know, we just want to be alive at the end of the day.
Exactly. Saving a life is never wrong. Katie? Is that the same hand?
Yeah, that's a historical hand. Sorry, I'm like very active in the chat, and there's too many things going on. Thanks.
Well, I was just gonna ask actually, if someone is new to working with people who use drugs and people who are experiencing homelessness, how would you ask them to proceed if if they didn't believe their client felt the same level of pain that they were speaking about and were asking for opiates? Like, what is your opinion on that, and how would you approach that?
Is this the drug seeking question?
Yes.
Excellent. So let's talk, if we can talk about, like, I know this is about opioid use disorder, but I'm gonna like frame it first by sharing my story of being a person who has neurodivergence, and after 8 years of abstinence from all things, I was on tons of medication my whole life since I was in mental health hospital when I was 12, and I was pumped full of medication, but they told me I couldn't use cocaine and I can't use fentanyl, like I was doing patches at the time, but I could take all the medication they prescribed me. And the courts are like, you have to take these drugs because a doctor says so, but you can't take these drugs. So I decided just to stop taking everything. And then I went to college at 40 years old and realized I can't sit at a Zoom thing without something. And I went to my family physician for ADHD medication, which is something I was diagnosed with years prior and hadn't been on medication for years. And we had the conversation about, like, but you have polysubstance use disorder. And I'm like, buddy, if I wanted stimulants, it wouldn't be Vyvanse. I'm sorry. And I think, like, to answer your question about opiates is, like, we can't determine someone else's pain. I don't know if there's a test. I work with doctors a lot of the time, and I don't know if there's like a test to understand pain. I think, like, if you break your leg, you know the person's in pain, but there's so many different kinds of pain. And I don't think it's up to us to determine what pain is. I think having an honest conversation with that person about risks and benefits is important. I think people that are informed and given the facts about a situation have the right to make that decision. If you're like, here's the risks if I prescribe this stuff, and the person's like, I will accept those risks, is the same as like, here's the risk if you don't go to the hospital, and the person's like, I accept that risk. And I think we just need to let people be the experts in their own life. And I know that sounds easy as a non-prescriber. I think, like, it's easy for me to say, give the people what they want. I have this conversation with my colleagues all the time. I'm like, let's just give them the drugs. Because that's my mentality as a person that used to sell drugs. I didn't question why people were asking me for them. But I know there's, like, the CPSO and, like, all the governing bodies with physicians. So I know you can't just be like, here's all the pills you want. But I think having an honest conversation and looking at what your own reluctance is as a prescriber, as opposed to what that person may or may not be honest about.
Mm-hmm.
Where is your own bias and inability to trust what they're saying?
Yeah, open and honest conversations and, like, that good rapport and building trust is really, like, have a relationship with your patient, and you won't have this issue. Like, if you have a real mutually beneficial relationship. Lauren?
I'm basically just going to echo your sentiment about not gatekeeping drugs, trusting us, giving us the autonomy to know our bodies and our pain management, and just that trust that we need. Because as soon as if you don't trust us, that's the basis of relationships. We're just not gonna go back, and we're gonna go to the streets. And it's like drug seeking. It's so easy. It's to call a person who sells drugs and get exactly what you need. I can, get Xanax. I can get oxys. I can get whatever I want delivered to my place, and within an hour. So why would I take the time to go all the way to the hospital or see my doctor to try to get these drugs that are very easily accessible? yeah, just I mean, if you're worried about why we're taking them, maybe get like, yeah, we'll have that conversation about our trauma and like get to know us more and why where our need for drugs is coming from. Is it more than just physical pain, right? Offer us different therapies and explore that with us. Don't just be black and white thinking with like, hey, it's just you need to go to 12 step or be abstinent. Otherwise, we're just gonna run out the door, essentially.
Yes, and like you said, the medications that you do have as a doctor to prescribe that even in safe supply programs, like they're not effective. They don't do what people want them to do. They don't get us high anymore. So I feel like yeah, honest conversations. Sylv?
I just want to say, keep in mind too, like, yeah, like pain, like opiates are really great for emotional pain and everything, but people who are homeless like tend to, I know when I was homeless, like my feet always hurt, my back always hurt, my neck always hurt because I was walking around so much. I was finding uncomfortable places to sleep because you slept where you could survive, whether it was on pavement, whether it was on some cardboard you found in an old parking lot or a garage. You do get a lot of pain actually being just homeless from walking around, from your feet, your legs, like because you're moving so much and everything. So that is just playing on the side that, yeah, they could actually have physical pain just from being homeless. Think of that next time you're talking to them, that's all.
And like we said, we are resilient people, and people who are homeless are very resilient, and they take a lot of S. So their pain tolerance is probably really high, and if they're asking for something, they might not be showing their pain, but they might feel it, you know? So I guess we have just 3 minutes left. Does anyone have any like quick last minute, like one statement kind of things to leave off with, well, so people know what we want them to know before we go?
Perfect. Sean asked a question in the chat, and I don't know if anybody's seen it or answered, just about like what it is meant for our lives to do the work that we do. So I'm gonna end with that. And again, my experience with substances, illicit substances, was in the past, but it's very much still a part of who I am and will always be with me. And my experiences are like shape what I do. But one thing that keeps me on the path towards what I'm doing and what choices I make is walking beside the people that are making different choices. And I am honored and humbled. And I think anybody that has an opportunity to walk alongside someone as they chart their own path and find their own goals and dreams, in any part of their life, whether it's a week, a day, a month, or a year, should be honored and humbled to get to do the same. I am forever grateful for the people I work with, the people I've met, and the people I have lost. They will forever shape who I am. And if you're just getting into this work with people that use substances, people that are homeless or deprived of housing, because they're not actually homeless, there's just no home given to them. The easiest way to start and to be of service to that person is to just simply say, hello, what can I do for you? Instead of why are you here, and moving on to the next person.
Anyone else? Well, I'd like to thank everyone on the panel for being here today and sharing your experiences and your stories. We're so grateful and honored to have this great panel of speakers. And I learned a lot today. I think folks in the attendees, I think they've learned a lot today. And I just want to really reiterate that we're humans, and as we're doing this work, we are also being traumatized daily by people dying and the stigma and discrimination. And it would just be nice if we had the support we need to be able to do the work and just make it through the day. So yeah, thank you for coming to our session, and we appreciate your time.